Hi everyone, my name is Lawrence Lapana. I'm one of the first year anesthesia residents, and today I'll be going over PACU care for patients with peripheral nerve blocks. My objectives for this talk is to understand the basics of choosing patients for regional anesthesia and then go over briefly how nerve blocks are performed. And next I'd like to identify potential PACU issues in patients with peripheral nerve blocks and hopefully help you troubleshoot some of the problems you might encounter. So there's essentially two types of regional anesthesia, and I'd like to define what is a peripheral nerve block. There are two types of regional anesthesia, like I said, the NEURAXIAL block and the peripheral nerve block. The NEURAXIAL block, or as we more commonly call it, a spinal or an epidural, places anesthetics into the central nervous system, which includes the brain and spinal cord. A local anesthetic can be placed into the subarachnoid space or the epidural space, and this can be accomplished as a single injection or with an indwelling catheter. The picture here shows the anatomy of a neuraxial block and the two spaces in which anesthetic can be introduced. The white space where the needle is shown is the epidural space, which is where the epidural injections occur, and the yellow membrane deep to that are the dura and the arachnoid, and the white area in that where the cauda equina and the spinal cord rest is the subarachnoid space, so that is where a spinal injection would occur. Here we have a picture of the segments of the spinal cord and the different areas and surgeries that can be affected if regional anesthesia is placed on that segment. In addition to the spinal cord, you can also see the nerve roots that come out of the spinal cord. So if you ever hear the term paravertebral block, the provider is actually referring to a form of a peripheral nerve block that targets the spinal nerves that branch out from a correlating segment of the spinal cord. A paravertebral block is considered a peripheral nerve block and has been used as an alternative to an epidural. As you can see here, the upper thoracic segments can be used for thoracic surgery, such as a thoracotomy, a pectus repair, and a thoracic aortic aneurysm repair. The mid-thoracic segments are used for upper abdominal surgery, such as an esophagectomy, a gastrectomy, pancreatectomy, and hepatic resection. And the lower segment of the spinal cord and the correlating nerve roots are used for lower abdominal surgery, such as an abdominal aortic aneurysm repair, a colectomy, bowel resection, and an abdominal perineal resection. So a peripheral nerve block may target a specific nerve or a field of terminal cutaneous nerves. It can be placed before, during, or after the surgery. It can consist of a single injection or have an indwelling catheter that continuously provides anesthetic. And the medication injected is most often a local anesthetic such as lidocaine or bupivacaine, or in rare cases, corticosteroids or other adjuvants such as epinephrine and dexmedetomidine. Here's a picture that describes the different nerve blocks that you can have when you do a peripheral nerve block. So they are a nerve block, a field block, and local infiltration. A nerve block involves the introduction of local anesthetic to the main nerve trunk, and it is located proximal to the incision site and has a rapid onset of action. A field block is closer to the incision but does not include the incision site, so it is slightly more distal, and despite being also rapid acting, it can distort the surface anatomy. And last, we have local infiltration, or what surgeons call local, and this involves anesthesia directly on the incision site and targets the small terminal nerve endings. So let's think about the patients that would most benefit from a peripheral nerve block. And like I said, peripheral nerve blocks do not have to occur by themselves. They can also occur along with sedation, general anesthesia, or with an awake patient during the procedure. Those that would benefit are those that are high risk for general anesthesia, and these would include patients with multiple comorbid conditions, so those patients with cardiac problems, pulmonary problems, renal and liver problems, as those can affect the metabolism of general anesthesia, and those with obesity. Those with airway concerns because of their difficulty with establishing an airway and providing ventilation are also patients that would benefit from a nerve block, as well as those who experience post-operative nausea and vomiting from general anesthesia. Another group of patients are the chronic pain patients, as they can have very difficult to control analgesia, and those with opioid intolerance who can have severe side effects from opiates. And then lastly, the surgical procedure also determines who would be a good candidate, as procedures that require considerable post-operative analgesia and surgeries where the anatomy would allow for a regional block. Some of the benefits of a peripheral nerve block include facilitating mobilization and the initiation of physical therapy, because once the pain is controlled in that local area, the patient is able to proceed with moving that extremity or that area of the body, and then being able to benefit from early therapy. Second is a decreased incidence and severity of ileus, and this is related to decreased opiate use, and the large benefit of this is that they can advance their diet much faster. Third is to minimize the use of opiates. This is both good for chronic patients and those patients that experience nausea and other undesired effects of IV and PO opiate analgesics. Next is the use of it in diagnosing and treating chronic pain syndromes. So this stretches out into the outpatient world as well as the perioperative world. And lastly, if you look at these all together, peripheral nerve blocks can advance the care with the goal of a smoother and more expedient discharge for our admitted patients. Some of the preoperative considerations, as most of you guys will be treating these patients both pre-op and post-op, is that first of all, we should have the ideal location. So first is the block room triage, and we do have a block room here at Yale, and so these are recommended in order to minimize delay and optimize bed management for pre-op, post-op, and for the placement of the blocks. This block room allows for pre-medication administration to treat apprehension or current pain symptoms, and this can also be done by oral medication as well. And then of course it's important to have IV access placement recommended before the nerve block is performed, because as I'll go over later in the talk, toxicity from systemic spread of local anesthetics can be experienced both in the pre-op and the post-op period. The patients should have standard monitors such as a pulse ox, an EKG, and a blood pressure cuff. And as part of their pre-op evaluation, the site of the nerve block must be considered for signs of skin infection, as this would, first of all, affect the spread of that infection, and two, it can also decrease the efficacy of local anesthetic. And then lastly, the preoperative assessment should also include evaluation for coagulopathy, paresthesias, and neuropathy, as you can have side effects of nerve damage and problems with coagulation during the procedure. So I'll briefly go over some of the common nerve blocks which you will see, and I have pictures of that on the right. I'll try not to go over too much detail about the anatomy, but it's more important to focus on which areas are affected so that you can tailor your exam accordingly. Some of the common blocks that you'll hear of are, first of all, the upper extremity blocks. So those include brachial plexus blocks and terminal nerve blocks. I have a picture of the brachial plexus here on the right, and it's essentially a set of nerve bundles that come off of the cervical spine and a little bit of the thoracic. and they provide innervation to the upper extremities. So the brachial plexus blocks include the interscalene block, which is listed here, and those are procedures for the shoulder and the proximal humerus. We have the supraclavicular, the infraclavicular, and the axillary block for surgeries distal to the mid-humerus. There are also terminal nerves, such as the median ulnar and radial nerve blocks, and then those are placed in the elbow or wrist for surgeries involving the forearm and the hand. The paravertebral block, as I mentioned earlier, can be an alternative to a thoracic epidural, and that's placed on the dorsal surface with the spinal nerve roots. And there's also a transversus abdominis plane block, which is placed on the ventral surface, and that's ideal for lower abdominal surgery and surgeries on the abdominal wall. And here are the target nerves in yellow on the picture on the right. As far as the lower extremity blocks, I have a little bit more of a detailed picture here. The lumbar plexus is the nerve plexus that comes off of the lumbar spine, but it's not as accessible as a brachial plexus and not commonly used for nerve blocks. So here we have a femoral, saphenous, sciatic, popliteal, and ankle block, and here are some of the pictures of the placement of each, what it looks like on ultrasound, and the distribution of the block is here below. Lastly, we have a beer block, and this involves local anesthetic introduced through the IV. However, there's a tourniquet, as you see here, in the upper arm, and that must be inflated for the duration of the block. This allows the local anesthetic to stay in a particular region and provide its analgesia. And once the desired block it has completed its function, the tourniquet must be deflated very slowly, and this is once again usually done on the upper extremity because the blood vessels and nerves are easier to localize. So there are a couple of ways that you can place the block, and again, I don't want to go over these in too much detail, but it's important in case your patients ask you how these blocks will be performed. The initial technique that was used when regional anesthesia first came about was a paresthesia technique. This uses surface landmarks to elicit paresthesia when the blunt needle is in the proximity of the target nerve. So this would essentially just focus on bony and fleshy landmarks to guide your needle placement. And this is now rarely done with the increase in ultrasound technique. The next technique that came about is the nerve stimulator technique, and this may also be done in conjunction with ultrasound. This uses insulated needles to induce muscle contractions of a target nerve, and once you have those muscle contractions and you know that your needle is in the right place, you can apply the local anesthetic. Again, this is mostly on motor nerves because you want to see the muscle contractions. Last, we have the ultrasound technique, which uses ultrasound guidance, and with this you can visualize the target nerve, surrounding blood vessels, and the needle itself. I have some pictures of these. This is a nerve stimulator. As you can see there, there's the insulated needle and the electrode, and then you can see both on the display and on the patient if you're in the right location. And here's a picture of the ultrasound, and as you can see, the transducer is on the patient, and then the small black circle on the bottom is what you would see on the screen. There you see the needle and the nerve, but what you actually do not see is that you can see the blood vessels as well that run with the nerves, and be sure to avoid those blood vessels when you're placing the nerve block. So what are some immediate PACU concerns as these patients come directly from the OR and have the nerve block put in? So first you want to check the neuromuscular function. You want to make sure that the motor, vascular, and sensory function associated with the block are assessed and are either properly providing analgesia and have no other neurovascular compromise. You'd want to look at the block site and check for obvious complications such as active bleeding infection, or a hematoma. And once you get sign out from your provider, you need to make sure where exactly the block was performed and if there's an indwelling catheter associated with the block. You'll want to look at autonomic function and look for signs for systemic anesthetic toxicity. And like I said, this can occur both pre-op, when boluses are given, or when additional boluses are given later. And I'll go over these in the future slides, and any anesthetic agents that are used with the block, such as more local anesthetic, opiates, steroids, epinephrine, and other adjuvants such as Precedex. So what are some of the signs and symptoms of local anesthetic toxicity? So first, you'll have some neurologic complications once the local anesthetic has either spread into systemic circulation or is inadequately metabolized and has now caused additional unwanted symptoms. Some early symptoms include circumoral numbness, tongue paresthesia, tinnitus, agitation, and a feeling of impending doom, which is usually associated with the spread of systemic epinephrine when it's used as an adjuvant. And later symptoms include muscle twitching, tonic-clonic seizures, and a coma. The treatment for these include benzodiazepine and hyperventilation, as well as propofol if needed for the seizures. And it's important to instruct your patients that neurologic paresthesia can take 1 to 4 weeks to resolve. However, there is a rare case when these do not resolve as well. So respiratory symptoms include a decreased hypoxic drive as well as apnea. Cardiovascular effects, as local anesthetics is a sodium channel blocker. You can have depression of contractility and conduction velocity, as well as arterial vasodilation, and you would see these through an abnormal EKG and hypotension. You can also get arrhythmias, heart block, and cardiac arrest in higher concentrations. So in addition to your ABCs and ACLS protocol, it is recommended to use amiodarone for some forms of ventricular arrhythmias. Musculoskeletal effects, in case the local anesthetic is placed directly into skeletal muscle, include myotoxicity, and these can take about 3 to 4 weeks to resolve. And the hematologic effects is a depression of thrombosis and decreased platelet aggregation, as well as enhanced fibrinolysis. So this can make problems of bleeding, as in the PACU. So, like I said, there are two types of peripheral nerve blocks. There's those that occur as a single injection and those that occur as an indwelling catheter. So with the single injection, these are normally shorter acting. So once the peripheral nerve block resolves, this may require a titration of analgesics. And since you may encounter the resolution of the single injection nerve block in the PACU, you'll want to monitor the return of nerve function and monitor for signs of systemic toxicity. And also remember that these can include adjuvants for added benefit, and these would be epinephrine, opiates, and less commonly steroids. So be sure to note those on your PACU evaluation and monitor for unwanted effects of those adjuvants. As far as the continuous nerve blocks, these are the ones with an indwelling catheter, and they can be an elastometric and electronic portable infusion pumps, and I'll show pictures of that in the next slide. The benefit of this is that you can have reduced resting and dynamic pain, as well as sleep disturbances, largely because these can have a basal rate with plus or minus boluses with the electronic pump. You can have ambulation and functioning improved because with the electronic pumps you can titrate boluses as they progress with their rehabilitation. And ambulation is also improved with a given basal rate. Some of the rare complications with the continuous nerve blocks include catheter retention, dislodgement of the catheter, nerve injury, infection, and a retroperitoneal hematoma. And just because these are continuous and there is a indwelling catheter, especially in the lower extremity, they can affect proprioception. So in case you ever help your patient ambulate, know that this can increase their fall risk. Here a picture of the elastometric electronic infusion pumps, A and B. Essentially the elastometric, what you will hear about this is the on-cue pump. So if someone says they have an on-cue pump, it's essentially an elastometric, which is a plastic or rubbery ball that injects local anesthesia continuously. And then the electronic pumps can be the Cadsolus or the Hospira pumps, and these are the ones that need to be programmed and stay inpatient. So like I said, the on-cue pump, when your patient has that, as far as discharge planning, you'll need to make sure that the patient has adequate education on how to use the pump, or in this case, how to not use the pump, as like I said, these do not require any programming, and it uses just the negative pressure from the rubbery ball to infuse the anesthetic. And then make sure that they're clear for discharge with the anesthesiologist and surgeon, and that they understand what the plan is for the removal of the on-cue pump. The electronic portable infusion pumps are only allowed on the floor, as this, like I said, requires programming. And for these, you want to make sure that you get a pain consultation, or have talked with the anesthesia team to figure out what the management is on the floors, as your typical floor nurses and hospitalists and intensivists are not usually the ones to manage these on the floor. And know that for discharge, this can affect the Aldrich criteria. So here are my references. Again, thank you for listening to this podcast, and hope you guys learned a lot and are now able to treat patients better who have received peripheral nerve blocks. Thank you.
Well done. Stop.